And now we go, e agora nós vamos para a próxima apresentação, que é para falar
And now we go to the next presentation to talk about the perspective to expand testing, the Act 8 diagnosis and its legacy. Robin will be the moderator. She was for several years regulator in TGA Australia with a great experience in diagnosis. From there, she participated in different activities, but we should highlight her participation inside the WHO in Geneva. And nowadays, she has a consultancy and she works in a frequent way with FIND and in other projects regarding world health. And besides great experiences, she's a great friend and she's going to bring the panel with a lot of new things, with a lot of, and Rosanna Peeling. Robin?
Thank you, everyone. Good to be here today. Can you see me and hear me? Fantastic. Okay, well, I'm going to, probably everyone knows everyone, but I'm going to soon introduce our panel. And I'm also going to quickly just give you a 2-minute rundown on what Act Accelerator is, just so that we're all on the one page. And so the access to COVID-19 tools is the Act Accelerator, and it's a global collaboration to accelerate the development, production, and equitable access to COVID-19 tests, treatments, and vaccines. It was set up in response to a call from G20 leaders in March and launched in April 2020 by WHO, the European Commission, France, and the Bill and Melinda Gates Foundation. The ACT Accelerator has 4 areas of work: diagnostics, therapeutics, vaccines, and the health system connector. Cross-cutting all of these is the work stream on access and allocation. The ACT Accelerator Diagnostics pillar is co-convened by FIND and the Global Fund and includes over 30 partners. Now, as we discuss the legacy of ACT Accelerator for Diagnostics pillar, let us keep in mind the potential powerful impact of pandemic preparedness, not only on patients, but on global economies and the development needs of individual countries. So with that in mind, I want to just introduce the panel. And first we have from CHAI, we have Renuka Gare, who is a global health advocate. She has an extensive background with industry and was VP for Global Health at BD prior to joining CHAI as Senior Advisor with the Global Diagnostics Group. Throughout her career, Renuka has worked on establishing new partnerships and programs to advance health access for diagnostics in low and middle income countries by establishing public-private partnerships and access programs. She has served on boards of ASLM, Project Hope, and is currently on the Ethics and Governance Board Committee of the Global Fund. So it's great to have you here on our panel, Renuka. Next, we have a well-known member of this team, Rosanna, who is Rosanna Peeling. Professor Peeling is Professor and Chair of Diagnostics Research at the London School of Hygiene and Tropical Medicine and is Director of the International Diagnostics Centre. She trained as a medical microbiologist and has been research coordinator and head of diagnostics research at WHO's special program on research and training in tropical diseases in Geneva. And she was chief of the Canadian National Lab for Sexually Transmitted Diseases before assuming her current position. And finally, I have a colleague of mine who I'm now working with very closely, and that's Dr. Sergio Carmona, who is the Chief Medical Officer for FIND, the Global Alliance for Diagnostics. Prior to joining FIND, Sergio spent over a decade at the National Health Lab Service in South Africa, where he specialized in molecular diagnostics and treatment monitoring for early infant diagnosis, HIV drug resistance, and associated co-infections. A clinical pathologist by training, Sergio has been involved in technical committees and initiatives led by WHO, the US CDC, the African Society for Lab Medicine, and the South African National Department of Health. So we really have a stellar cast here to guide this discussion on what are the perspectives and legacies of ACT-A in the context of testing expansion. So to start this interesting session, I'm going to ask Renuka to present for us. And thank you very much, Renuka. Over to you.
Thank you so much, Robin. I just want to make sure that you're able to see my slides.
Yes, that's perfect.
Okay, perfect. And as you said, it's a small world here. Everyone knows everyone. And I want to just start off by saying thank you to Carlos for the invitation. And also want to say that it's a privilege to be speaking alongside Dr. Rosanna Peeling and Sergio, two people whom I admire very much for their contributions in global health. So I'll provide some perspectives. I think this presentation will be more like a starter for a very robust discussion with the fellow panelists. And I'll cover about, a bit about the background all related to the testing aspects, focus a bit on the what happened in as the pandemic progressed, and then conclude with some of the learnings and outlook, which is really hoping to get to the topic of what is the legacy of ACTE in testing. So the very first slide, I mean, it takes a village, obviously, and it's phenomenal to think that since April 2020, we have about 1.6 billion tests for COVID that's been conducted, thanks so much to the effort of ACTA, which really pulls together key stakeholders, countries, governments, partners, implementers, donors, to be able to make this happen. And CHAI is one of the supporters and partners of the ACTA pillar, very actively engaging with FIND and other players. And in this space, CHAI has also done some work with other donors, which you will get a flavor of what was done. But this slide is self-explanatory. You can see that industry came together, pricing got really attractive, new tests came to foray with molecular and antigen, and WHO played a very critical role on how to get these products through a EUL regulatory path, if you will, and FIND played an incredible role in looking at how do you look at specimens and ensure quality testing, alongside leading the whole pillar, so to say. And it's not done, right? Because we're still talking about COVID, we're still talking about how do you make this routine normal and what could be the next tools in the toolbox. If you look at a simple way of stating what I was saying is probably you have a phase one where when the pandemic began, everyone were looking at what can you do to test with existing PCR systems that are prevalent in LMICs, whether that's manual PCR or automated PCR. And then there was this phase two, if you will, which is looking at how do you decentralize these testing? How do you make it more point of care to where the person is? And how can you make results more rapid, which led to the creation of an antigen rapid test category in record time. And then we're now talking about a whole bunch of newness in terms of what next and how can you even make this available in the hands of the individual user through self-testing, and much discussion happening in that space. A big legacy is to say that you can look at an entire cascade of health system, and each of these tests, whether that's central lab, rapid tests, and self-test, has a role to play, and that's kind of happening real time with the COVID pandemic. So again, the very first testing efforts were looking at manual PCR. What can we do? How can we talk to suppliers, automated PCR providers, and say how can they allocate some supplies to low middle income countries, which has always been a challenge, but we were able to do that. Several folks came to the table and establishing the diagnostic network and capacity. And then there was country preparedness that had to happen to say, How can you look at procurement facilities? How can you look at scaling? How can you look at leveraging your own lab networks? And how do you look at doing all of this while you're still trying to continue your care and treatment with other disease conditions that these systems were intended to be placed for? And now we're looking at these conversations. This is a continuous conversation to say, how do you now look at integrating all this testing into routine services? So when after at the onset of the pandemic, I guess, several PCR platforms were in play, some more prominent in the low middle income countries, some more in the developed world, but that's where the journey started. And Chai, I believe, was one of the players looking at how do you procure, how do you look at demand forecast, how do you ensure that we're working with partners to make sure that there are allocation agreements in place, and ensure that the companies remain interested in providing these tests at a price that could be used for LMICs. And similarly, when you start looking at the next phase, then there was similar work to be done in terms of looking at antigen tests, which were rapid tests. There was a need to look at not only market readiness, country preparedness, but also evidence to say, do these tests really work, and where can they be used, and at what price can we bring them? And that was the focus of several of the actor players, using the same lens that they use for PCR, but then looking at antigen testing, which were new tests, and so meant a lot more new work from the very beginning, so to say. Again, in this space, several market shaping interventions took place. So I think there was a strong collaboration between FIND, Chai, several global players, BMGF, Global Fund, and finally there was volume guarantee agreements in place, pricing negotiations that took place with companies such as Abbott and SD, and Lumira, and very, very active progress where we were able to announce, that companies were, through the global partnership, are going to be making available 120 million affordable quality approved tests for low middle income country at less than $5, and now that price is even somewhere around the $3 range. So really, what an impact from where it began to how quickly the response was put in place. At the same time, organizations like BMGF were seeking to get in newer technologies into LMICs to look at an assessment. For example, we worked with Lumira Diagnostics and as part of the Gates program to look at the feasibility of this new diagnostic across several countries. Similarly, worked with Mologic, yet another company, to look at what do they need to do for a pathway to scale. So it was not just looking at the existing players and what they had, but also cultivating newer entrants into the field, so to say. As phase two, there was also a great recognition and realization that you can have the technologies, but you need to really work alongside with countries and with stakeholders who have that influence in countries to look at what are the strategy or the guidelines and the implementation plans for scaling these tests. And here are some of the examples very specific to Africa, where there was this Africa's PACT initiative was established. There was guidance developed in collaboration with Africa CDC. Several players, many of them who are on the call, whether it's WHO, FIND, ASLM, Chai, came together to develop training materials, wide dissemination of the training materials through knowledge sharing platforms and webinars. A lot of them were led by ASLM. Tremendous support by WHO, and all partners worked collaboratively with WHO to develop some of these tools, guidelines. And we found that in many of the countries where we directly operate, there was really tremendous progress in terms of using an Africa CDC guidelines, in terms of the testing and material and actually procurement via the Africa PACT platform as well. So you can see that on one hand, it's the market readiness and industry, but on the other hand, it's the country readiness and adaptation and guidelines, which all need to come together. If you look at the next slide, then really what we were looking at is a whole bunch of planning, regulatory pathways. Rosanna can talk to that more than anyone else. Looking at procurement, deployment, and user training, systems within the country, and data management. All of these need to happen. Some are happening more immediately and naturally, and some where there's a lot more work that can be done. In the process, CHAI also conducted a bottleneck analysis that identified what are the key gaps by country, to understand where is the need, where is the action that needs to occur. We shared this report widely with global players, so that you can collectively guide resources to the right attention, right action. Sometimes it could be ramping up procurement faster to look at better planning in country. It's simply advocacy and lack of immediate knowledge, or the fact that the country hasn't fully decentralized. So country by country, there's some recommendations, and now there is a whole focus on saying, how do you address bottlenecks relevant to each country so that we can make a better progress too. So that's another interesting learning, I would say. But this slide says it all in a way. Testing, though we can celebrate, we've done 1.6 billion tests, we still find that there's a big gap, and that there are disparities in countries, particularly across income groups. And so there's good progress, but the job's not fully done. There is a need to invest on demand generation, advocacy. How do you bring testing to the community level? And what are the market shaping interventions to make these tests more affordable? That's something that is an ongoing discussion and an ongoing need, because just yesterday, I think we had Africa CDC made a presentation in one of the forums, in the PAC forums actually, where you talk about how still a majority of countries are not yet where the WHO guideline is for the testing data, and the gap still remains very high. Also, the gap becomes higher when you're between two pandemics, when there is a softer spot where testing interventions just stop because you don't see the same pace of positivity rates, perhaps. But one of the other challenges and things that we're still working on is actively tracking this test and treat, so that countries can have a policy. Now that you have vaccination, you're having therapeutics, how do you create systems and policies to look at this continuum of care, and make sure that you're testing before the right treatment is administered, now that there is treatment, thankfully, available. Also, the biggest thing that we are now discussing is, how do you make testing more routine? It's one thing to respond to an emergency, but when it's normalized, how do you look at integrating COVID testing with other disease states so that you're not disrupting any other utility of the equipment, but that indeed this becomes the regular, normal state of affairs. And I think FIND is doing some really good work in looking at what are the other aspects that can be integrated into routine testing, from not just a COVID point of view, but related respiratory. I'm sure we'll hear about that from Sergio. And finally, Self-testing, I mean, even today, I mean, the biggest self-testing market still is in the developed world. And there is an absolute need to look at how do you bring testing to communities? How do you make sure that people have the choice to test when they when they can, and to then practice isolation on their own. Again, also there is a big need then with the self-testing to say, how do you look at particularly targeting vulnerable groups? How can you look at healthcare worker screening? What are the other use cases for self-testing? Schools, pharmacies, how do you look at the entry point? A lot of work has been done on travel, but really making these available first and foremost, and making sure that between the waves, you still have the that still testing is kept alive. And I think that's where I think there's a lot of, again, good work you'll hear from FIND in terms of what they are doing with self-testing, and how they're aiming to bring the prizes from companies that are focused on LMICs. But CHAI is very much engaged in looking at country readiness, country preparedness, and making sure that these initiatives that are an ACTA priority are indeed well executed, implemented, so that we can make a big difference in the pandemic. So again, in conclusion, I'd like to say it is a continuous process from how do you look at these testing, how do you link them to care, whether that is test and treat, whether that is rapid test or self-test, where you don't have necessarily a ready system to connect and collect data yet. But how do you look at making these linkages to care so that you can improve testing coverage, and how can you look at normalization of testing? Anita spoke very elegantly about sequencing and surveillance, and that's another area where we are currently looking in collaboration with FIND to do a landscaping, to look at what are some of the challenges in understanding the sequencing landscape today in a little more detail, with challenges at the country level, and then come up with a plan for potential interventions. Hopefully over the next few months, you will hear more about this project. And yes, Carlos, we do have Latin America countries, not Brazil yet, because we couldn't put that into the current proposal, but I think there'll be a lot of good opportunities for further engagement. And this work that we're doing will be representative of all 3 continents, like in Latin America, there'll be information from Asia and Africa. And finally, I think the other big trend and legacy that we see is local manufacturing. Lot of good discussions, some bold commitments and investments to make sure that there is a readiness to respond for now and for future. So I think in summary, Robin, I'd say that this working together with ACTA and the legacy that ACTA has will be leaving behind is multifold, from bringing together various players to utilize their core competencies such that you're engaging the global village for what they can do best, to looking at how do you leverage existing technologies, how do you bring new ones, how do you look at country preparedness, what's the role of policy, and how do you look at new tools and be better prepared for the next outbreak through sequencing, through deploying self-tests, and ultimately by encouraging and advancing local manufacturing, even if it is not because the prices will be cheaper, but it is an economic consideration and a readiness and preparedness consideration. So I think a lot of good lessons and legacy that ACTA has and will be leaving behind as far as testing goes. So thank you for the opportunity, and back to you, Robin.
Thank you, Renuka. That's been comprehensive and really fantastic. And I'm sure that you've stimulated a lot of thoughts on all sides of the table here. So Rosanna, can I just get you to put on your camera and join us? I don't know, Carlos, can we have all presenters showing on a screen, or is that possible?
I think so. Bruno, você consegue liberar os 3 na câmera? Por favor.
Bruno, can we have all of them on the screen?
And there's Sergio.
You too, Carlos.
Hi.
Rosanna.
Yes.
Hi, Rosanna.
Hi.
Hi. Good
So
to have you. Can I turn over to you for to talk next? Can I get your just a few points, because I've got a lot of things I want to throw the panel's way in the next 40 minutes. Can you tell me what you think of some of the big, most game-changing legacies from ACT-A Diagnostics pillar?
well, there's a lot we could say, and Renuka has really done a great job presenting everything that's happened in a chronological order, so that we could understand how we've arrived at where we are today. But I think that if we still are looking at different countries, there's still a huge difference between how the pandemic is being managed in high-income countries versus low-income countries or middle-income countries. Because I think that, while ACT-A has been very successful in advocating in negotiation with industry, because industry has done a fantastic job responding to the pandemic with so much technological innovation, capacity to manufacture on a scale that's never been done before. But in spite of all that, where the question of the matter is that in countries, we still have problems that have existed before, which is when a new product is, a new diagnostics product is being submitted to regulatory authorities in countries, a lot of countries still demand to have clinical performance studies done. And so one of the first companies that came up with an antigen detection test said, the company said to me, they are being asked by 60 countries to do duplications of clinical performance studies, in spite of the fact that the test has WHO emergency use listing and FDA emergency use authorization. And this is a pandemic situation, but these things didn't change. And so in spite of everything that ACT-A has done, we're still running into some roadblocks in countries. And then subsequent to regulatory approval, or in some countries where they actually accepted the performance from that's based on the emergency use authorization, the second big roadblock is policy development. Some countries are still waiting for WHO to recommend the use of antigen tests for asymptomatic populations, because WHO came up with the guidance for use of antigen tests, but mainly for symptomatic individuals in countries where PCR may be not available or is too slow. And to this day, WHO still hasn't come up with the guidance for the use of antigen testing for asymptomatic populations, which is really a shame, because as a public health tool, antigen testing could really provide people with the confidence that they will be able to go to school, go to workplaces or mass gatherings, and be in a safe environment. So, I think that antigen testing has very good predictive values for, a negative result, right? And so, but in spite of that, a lot of countries were waiting for WHO to make that guidance before they would develop their own guidance. And then ultimately, also in some countries, the even when they have to test, is this health system failures. Failure to distribute, to train enough people to, or to even get the test in the hands of the users. And so I think that we need to do a bit more, I guess, go that last mile to try to help countries. So ultimately, in the next pandemic, health systems needs, you know, or in the inter and epidemic phase, we need to put a lot more effort into health systems strengthening and regulatory practice and policy. Over.
Thank you very much. And I can't believe, you know, you and I have been having the same discussion for about 15 years about why do we have to have so many performance evaluations? Nothing's changed, has it? And it's quite unbelievable.
Yeah.
And with I'll just quickly ask you a question on this, with your statement around missing policies from, especially from WHO, because so many countries won't move ahead without that.
Yeah.
That, you know, there's some argument that there's been lack of evidence in, you know, maybe for some of the things to form guideline development policies, but I just wonder if in an emergency, you know, should WHO be considering a lower level of evidence is, you know, like the harm of omission is worse than the harm of commission.
Yeah,
and
exactly.
So, and then finally on health systems, yes, I think it's been, I think we're all waiting for the next wave of cancers and everything to come through because of everything that stopped in the absence of, you know, labs or facilities being overtaken with COVID testing. So yes, some really great points. So I'm going to turn to Sergio now. Hi, Sergio. Do you want to give us a quick rundown on your view on the legacy with testing? And also, I think if you can maybe a couple of points. Oh no, we'll come to them later. You go ahead and then
my views on what happened. So of course, FIND was Renuka even before Chai was even on the scene, right? We FIND, for those who may not know this, and Rosanna, I know you were part of the inception of this. FIND is the Foundation for Innovation in New Diagnostics. We are a Swiss-based foundation here in Geneva, and probably the only WHO collaborating center purely focused on diagnostics. Our history started with TB, it evolved into hepatitis C, and I think I might have seen Sonia, one of my colleagues, on the and through TB, and as Anita presented, we started next-gen sequencing work. So we've grown from very much focus on one or two diseases into now being one of those who responded to the diagnostic needs of the pandemic. And maybe just to bring, Renuka, a high level of what ACTA was about, since Rosanna pointed out the health system, is that ACTA quickly formed as a coalition, a very loosely arranged coalition of partners and people like you, Rosanna, and many others that were in the mix, with maybe 4 pillars in mind. One, which was going to look at vaccines, because we knew one day we would need, that could be the only tool we had to curtail the pandemic. 2, we knew that diagnostics was probably going to be the first tool that we had to identify, contain the pandemic. 3, treatment, and that was slow, but now we get in there. And the 4th one, which was a cross-cutting pillar, if you want, pillars don't come sideways, but a base, was health system strengthening. And we together, FIND together with the Global Fund, co-lead the diagnostic pillar. And within that falls, Chai and many other partners. WHO was key also in terms of successes initially, where demand for diagnostics, if you remember 2 years ago, was highly sort of pivoting to high-income countries, so those who could pay, could get. The availability of raw material became really tricky. So we've been talking for years as well around decentralization of manufacturing capacity. Renuka, you come from the private sector, you know what challenges that brings. Rosanna, we were in Addis, I think in September before the pandemic, discussing how Africa could address this. And we all got caught in January, a few months later, completely unprepared, even on just the diagnostic. In terms of successes, this coalition worked at least for that pillar, in that we had Global Fund, UNICEF, the agencies that could procure. Together with WHO, the Diagnostic Consortium was set up to have at least a tool to distribute equitably in the global south, or member states that did not have that buying power, to secure some diagnostics, and then became very soon quite high in the agenda that molecular testing, remember, was not going to serve everyone. We knew that the infrastructure to address large number of infections and break the chain would require a lateral flow, affordable and rapid turnaround time of results, etc., that you all know. All of this in a very short time, in a record time. Actually, even within 100 days, we were pretty much there. It was scaling up to volume that became tricky with a very broken logistic and supply chain system. So in terms of legacy, from vaccine, diagnostic, treatment, and health system strengthening, I would say the diagnostic pillar did fairly well. Of course, we could have done better, and we could have done the scaling up of diagnostics and equitable access better. But it wasn't the actor's prime goal to now get in the weeds within countries. We were trying to empower by making available and transparent access to diagnostics. I think political leadership in some regions was more successful at getting that right. But I think, I don't want to get into the politics of those who did or not believe on COVID, which reminded me of the HIV days. So there was, I think, a little bit of short-term amnesia that this was not in an environment that testing and acceptance that the virus existed and could cause severe syndromes and death easily, right? Never before I've seen diagnostics become so mixed with politics and politicians, which is a good thing, because maybe testing now suddenly, we saw even the White House being aware that this is valuable, etc. So in terms of legacy, building on, I would say, the diagnostic literacy that exists today, right? That the systems may be still a long way to go, but the infrastructure has been put in place or has been invested. Rosanna and many of you here know how vertical programs like HIV, malaria, and TB were so protective of their turfs. And we talked about synergy, synergy, synergy. Today, it took another virus, another pandemic to see that we could use these platforms for other than TB, HIV, etc. I would like to see that legacy now benefiting other burdens of diseases in South America, Asia, and Africa as well. We have not contained TB, HIV, and in women's health, for example, cervical cancer screening with molecular HPV, for example, is underfunded and requires a lot of advocacy and demand, as you pointed out, Renuka. So this is an opportunity to ensure that what we've learned from genomics, from what it takes to produce an at-scale rapid lateral flow assays, introducing it as a self-testing, which we have done in HIV, which we have done in Hep C, learn from that. However, integrating all of this within our health system is important. Vertical parachuting of new tools, as we know, does not work. It can be disruptive, and the healthcare worker on the ground and does not benefit from that at all. And I would say the last bit is that digitalization of diagnostics has been successful in some areas. It will bring diagnostics to decision makers much faster if we can get that right. So the balance between protecting our own personal information and the benefit that that may have in a secured way to public health authorities to look for outbreaks, to see when will the last COVID test become positive, a bit like what we've done with polio and surveillance, is something I think we have started, and hopefully that legacy could continue. I see now more than before the integration with surveillance and routine diagnostics, for example, with COVID, is starting to happen and mutually benefit each other. So let me leave it at that. I think the rest is more detail, Robin, about our investment in innovation, technology transfer. We try and actually, with Brazil and Senegal and South Africa, it's hard work, it's not the entire solution, but hopefully Brazil will lead the way in two things, Carlos: technology transfer in a healthy market, and two, and I know some colleagues from Anvisa here, in showing us how a regulatory pathway can be enabler and also support good quality diagnostics. So, yeah. Se você quer que fale português, pode fazer também, para estar claro.
I can also speak Portuguese, so it's clear. Thank you so much. Perfect.
If you allow me just to make some comments. It's a great panel. It's such a pity that it has a time to end, because we would like to keep talking. We have so many things to share and to discuss. But what I think it's really important is that we finally perceive it, and also the population, the value of diagnostics. It's very much clear to everyone how important it is to have access to the right and early and precise diagnostic tool in order to be accessing the right therapy and then becoming going to another level. That's one. With the health, with the self-test, I think we were able also to break a very big paradigm, the one of disease. We actually can empower and prepare the population to look for prevention and to look for the self-care. So it's a big change. The COVID self-testing, in order to be allowed in the case of Brazil, it promoted a very important discussion, which will probably lead to discussing other possibilities. Like you mentioned, Sergio, very well, and I know FIND did a great job together with WHO hepatitis C self-testing tool. It's another important point for us here. We have over 500, almost 600 potential hepatitis C positive people that don't know. It's a silent disease and they don't know they are positive. So how can we look for them? That's a very good question. And self-care through the self-test is a possibility. But anyway, I would like also, you mentioned Anvisa. It was possible in Brazil, not only thanks to Anvisa, but to the Clinical Pathology Society, to the ABRAMED, to the Clinical Analysis Society, and so many other civil society members to join efforts in order to bring solutions so we could promote access to the best quality and effective test. That's one. To give several indications of potential ways to follow. And Anvisa was brave enough to use Reliance tools as never. Reliance nowadays, at least in Brazil, is a very important tool. And I know several other countries are following the same, because that's the good way for you. Do not reinvent the wheel. We don't have time for that in a pandemic situation. So we have to use what has already been tested, what is clever, and of course, from whom we trust. So this reliability among regulators is quite important. And the entities that from the civil society can also play a role supporting these decisions with mechanisms like we did in Brazil as well, with the program for assessing COVID testing, together with 13 public and private labs organized by the medical societies I just mentioned. So these are, in a nutshell, some of the examples that I do hope that we remember them in the near future. One Health is the clear situation nowadays. Environmental, animal health will impact human health. That's clearer than ever. And so we must be prepared for the next situations. Back to you, Robin.
Thank you very much, Carlos. And it was great to hear you talking about, self-testing and perhaps the potential now to make that easy jump to other diseases. So the generalizability of what we proved, you know, that what this whole pandemic has proved, I think we've got to see what are those wins that are generalizable, that we can take the next step further. And I think that's really important, and not let that go. I want to just pick up on something that Sergio said, and I think it's been, everyone I think has said it. None of our mothers or fathers or cousins or whoever knew what a PCR test was before. The world talks about them now and understands how they work. So diagnostic literacy has really improved. As you say, people know about diagnostics. We have this moment, I think, where, you know, we have still have on this momentum to do a lot of good, but if things aren't right, we can do a lot of bad too to the image of diagnostics, where money is wasted on the wrong diagnostic or whatever. So, and I think something that's been really, I think we mentioned politics, but it's impossible to take politics out of a conversation, I believe, because the politicians hold the purse strings for what happens in a country. And I think a very important role that ACT-A and especially FIND, it was some work from FIND, I think started it, was help bring to politicians' understanding the diagnostic use case, or the use case of diagnostics, that you can't throw any tool to any situation. So would anyone like to talk a little bit about this, what they see, you know, for the future, that, you know, under keeping in politician, well, in ministries of health, this knowledge that you do need tools adapted to the need. Would anyone like to talk about Accelerator's role in that, and where we see generalizabilities or future wins?
Sure. I mean, Rosanna, you were part of this too, but I think not only politics, I think now diagnostics is seen as a part of our global economy, our whole environment. And there were, ACTA maybe was criticized that initially was looking at this very much focused in the health sector. I remember the World Bank joined a few times, and the WEF as well. So we had, in terms of successes, we were part of a broader environment. Most of us come from the health sector directly. I trained as a doctor, and I knew what, you know, my lane, where it started, where it ends. And I think some of the successes were in looking at other areas. How could testing be done to open schools, for example, to ensure truck drivers could continue supplying goods in sub-Saharan Africa, crossing borders, open peri-mining communities, so some sectors could carry on work. So it's not only the politics, but also other sectors of our economy were interested in, never mind travel, but there was certainly a better understanding that these tools can also be enablers in opening the economy, in opening schools, etc. I think the UK, and you've seen in many media, that you could see teachers now demanding rapid tests to open classrooms, etc. So there've been certainly some gains there. I know immunization programs in the past in many countries had some interaction with the Department of Education, but so there's certainly some wins. I don't know, Rosanna, if you want to expand on that.
Yes, Sergio, I think that I think politicians are now understanding that we need a portfolio of different tests for different phases of the pandemic and different uses in different communities. So I've been asked about, how do we transition what we've done in the pandemic to future pandemics, and I've said that to so many governments now. I hope that someday it will become true, is that I'd like countries to be able to now think about investing in a diagnostic system that is the backbone of the healthcare system. So it starts from very sophisticated instruments at the top, reference labs, together with sequencing, all the way down different levels of the healthcare system in hospitals, big and small, and then in communities, and then in homes to be able to do self-testing. So this whole, instead of a lab system in a country, we want to call it a diagnostic system with connectivity, just like Sergio says, you know, the digitalization of data is really important for timely alerts of possible outbreaks. So this diagnostic system can become the eyes and the ears of the healthcare system, listening to unusual trends, not only for infectious diseases, but for non-communicable diseases as well, such as, you know, diabetes, heart attacks, etc. But having that as a basic investment would be very, very important in strengthening the healthcare system, making it more efficient, so that politicians are always happy to hear if you say that you're going to save money, but invest first and then you could realize the savings, which sometimes is hard to convince. But I think that's how we need to go forward.
Renuka,
So
do you want
Robin, if
to
I can add my comments to this conversation, I mean, just very quickly, I mean, health is a political issue, right? And global health particularly. That's why you have disciplines called the global health diplomacy, because there's a ton of negotiation, consensus, compromise. You're connecting with multiple stakeholders and actors, especially when you see that bugs cross boundaries and health situation somewhere means a threat everywhere. So I think this will become and is therefore a political issue. And what my comments would be is to mobilize this wonderful progress, even if that's not complete, and build on it, because we've gained momentum with diagnostics. I recall in the early days of the pandemic, and those who were doing some travel, even though travel was limited, even at airports, people would ask, is yours a PCR test or an antigen test? And this was a dining table conversation in families to say, what test is more appropriate? So to build on that momentum, but there's always going to be politics with ministries of finance, ministries of health, ministries of agriculture. Carlos mentioned One Health. And so it's how do you diplomatically build on this momentum to make this stick and stay beyond COVID to a broader set of disease states. But you can't avoid the politics. That's the nature of the field, so to say.
I guess, you know, something that I've always thought about, and I'd be interested in a few comments on, is we all know the cost of quality and, you know, getting the right result, and we can see the impact of that. But no one really knows the cost of lack of quality, you know, and when I say quality, it can be about the diagnostic itself or about the diagnostic service. So, you know, has Act A had a role in this, you know, thinking about, I guess it's an impact result, because I think the best way to convince politicians is to show them the savings they make from having a strong health system that's based on good diagnostic systems. Any comments on that?
I would raise, Robin, that the impact, the financial impact of diagnostic in the healthcare is very minimum. We assume it's something like 2% of the total healthcare GDP. It's really nothing, but it's a very important investment, because just by having the right therapy, you avoid returns not necessary to healthcare system, to labs, to hospitals. You go really very effectively to the final result, what is going to come with the solution or healing or whatever. So if you invest,
I would agree.
Yeah, you invest so little in a better diagnostic tool, in a better environment. And Rosanna always says, the right test for the right patient at the right time, at the right environment. So we have different solutions for each situation. So sometimes to pay a little more in a point of care rapid test means a fantastic, huge saving in the overall healthcare policy expenditure. And why? Because you avoid that person to overload an emergency area, or to take a bed unnecessarily in the hospital, or even antibiotics, and then we come to AMR, antimicrobial resistance, which is another problem, but it's linked to the wrong use of the health tools. So yeah, that's something I see.
And maybe as we see the implications of routine testing being stopped or, you know, overloaded systems, we'll be able to count some of that cost of not having good diagnostics in place. Maybe it's the opportunity.
Talking about quality, Robin, yes, and I'm talking, it sounds like a godfather of this, but it wasn't so long ago. I think Brazil, Spain, and some other countries bought large quantities of RDTs, lateral flows, that had very little regulatory approval or consideration. I think just to balance my statement here, FDA and serology stepped out because of the emergency needs. So I think, you know, we forget what happened with when there is no regulation, or where there's a waiver, if you want, right? The FDA said, okay, in serology, we're not ready to address all the needs, go ahead. And you know what happened in the US? Spain bought a large amount of RDTs from another country for serology screening. So here's where we have experienced that what happens when either the use case is not properly defined, or poor quality or counterfeit diagnostics into country. So that doesn't, any politician or any health system or MOH would like to publicize much, but it certainly happened and made it all of us very aware. And FINE was tracking that landscape very carefully to see what was going on in terms of claims, production, and as Renuka pointed out, commitment to make these products available in the countries and regions that we were interested to support, which wasn't always the case. So yeah.
I'm just going to quickly put up one last topic because we're nearly out of time, but I just think when we think of the legacy of ACT-A, I'm going to also think about a fairly new intervention, and that is the EDL, the Essential Diagnostics List. You know, that's only been in existence for the last 5 years, and you know, Sergio, you might.
I hope we're going to run out of time soon.
But I think, you know, with the importance of an EDL, it can't be denied, you know, and it's saying you need these basic diagnostics in place. Does anyone want to comment on that? Renuka, I'll give you first.
Yeah, put Renuka on the spot, this one. The value of an EDL.
Oh my God. So I think really there's no time. We could go on forever. And Sergio and I particularly exchanged some more recent conversations on doing.
Don't bring me down on this one.
Okay,
this is Renuka's personal view on the value of an EDL.
So listen, having an EDL is important. Otherwise, you know, when people talk about do you need an EDL or not, I think it's not in question, because the fact that you're talking about diagnostics and talking about in the context that it is essential, it's for the first time. And so come on, EDL is therefore very necessary. Now, what I would caution is an EDL shouldn't become a document that just gathers you know, dust, or that remains guidance without actual implementation. So how do you assess EDL is by having a country specific, what is relevant for the country, take the WHO guidance overall, but develop what's specifically suitable for your country. And more importantly, how do you action it? And EDL is not a one-time job and here's your EDL. It is a constant, like with any of these continuous programs. You got to visit, revisit, adjust, readjust as there's progress in health systems, as there's change in disease patterns, and as there's change in technology. So I think EDL is essential, and I'm happy that there is discussion around diagnostics as being essential. So that's my personal view. Thank you.
I think that's
Robin, to tie this out, in medicine as a doctor, the essential medicine list is no-brainer. People don't even discuss it, right? now with Lee Sheridan and many others, we even as a community doctor in South Africa, I knew that that was the minimum that I would find in a little hospital, 300 beds. But what linked to how to use those medicine from a diagnostic point of view was not there. So in a practical term, of course it should be actually tied up with an EML, right? If you got this book of what the minimum medicines you need to practice safe quality medicine, the backside of the chapters that go in there should also have the companion EDL. There's no brainer. But EML is funded. So we know those drugs, you can actually make sure the pharmacist can order, and there will be a price tag and an inventory. It's not the same with diagnostics. So for me, an EDL would be, it should become this in terms of funded and part of the health systems and policies, the same as it is with medicine. Let me leave it at that before I get into trouble.
All right, Rosanna, and then over to Carlos to finish off our session.
I just like to jump in to say when I was at WHO, I actually advocated for essential diagnostics, and they say, no. We have essential medicines. That's all we need. Diagnostics is too complicated. And so I guess, and then finally, when WHO decided that it's time for the essential diagnostic list, I was on the first, panel.
Committee, yeah.
But the problem is that they chose it by disease, which is not the right approach. I actually agree with what Brazil has done in terms of the technology 4.0, where you define what a person needs from cradle to grave, and say, okay, these are what a person would need throughout the person's lifetime. And we must make sure that at each time in their life, they have the right diagnostics. I think it's better to have it as a health tool rather than a disease tool. So I think it's now sort of giving the wrong perspective. Yeah,
that's very interesting. So, but at least it's, we've got something on paper now. We've got a starting point. Let's hope it doesn't take another 10 years for it to be the effective tool we needed. Yeah. Anyway, Carlos, seeing you own this show, would you like to have some last words about anything to do with this topic, legacy?
Yes. Just for clarifying to our Brazilian audience, EDL is the essential diagnostic list that is published by WHO, and it was fruit of a discussion. And but the key point is like what Brazil does. We do have to promote this discussion with the medical societies in two areas: the public healthcare system through the CONITEC, and the private sector, which is the ANS, which is the Supplementary Health Agency. And that's done with very robust evidence that it's a product or a technology or a system can be incorporated or not. So with that, we have been able to have, let's say, several products already incorporated, which means reimbursable in the private system or given for free in the public healthcare system, even as companion diagnostics, Sergio. So for cancer, for several situations. So it's a more holistic and more a broader approach, and it's always based on evidence. But anyway, once Anvisa approves a product, so gives a registration, that can be used anyway in the system. So I agree with you. At least this is EDL is a starting point, but it should not be only that. So I think that's the point. Each country should have the conditions to discuss with the involved stakeholders what is really necessary and to promote not only the incorporation of new diagnostic tools, but also to discuss obsolete technologies, obsolete. So the ones that are no use anymore, that should be withdrawn from the system. That's very important to keep sustainability for it. So with these words, Robin, I give it back to you, and in order to move on for the next session. So please, if you want to make the conclusion for this, and fantastic discussion. Thank you all, guys.
Yes, thank you, everyone. I really appreciated your inputs, and it's been a vibrant discussion. And I think we all can say one of the main things has been that there is good diagnostic literacy, and we must keep this momentum going. So thank you all for a great discussion, and look forward to continuing it later on. Thanks.
Fantastic. Thank you, Robin.